Dr. Ed Zimmerman, Aesthetic Revolution Las Vegas, bringing you another segment of our podcast, Aesthetic Revolution, the podcast, where we talk about aesthetic issues from forehead to feet and everywhere in between with my hostess, Staci Taylor Zimmerman, who keeps me from diving down the rabbit holes. But here's a rabbit hole that we get asked not infrequently. So, Doc, I fixed my face, my neck, my décolleté. What about my hands? And, over the years, we've developed a lot of ways of treating aging hands. First, we go back to why do we see the aging in hands? Yeah. So we certainly see the volume loss. As we get older, we lose our subcutaneous tissue. And so we have volume loss that reveals the extra veins and the tendons and all those kinds of things that we associate with an older age. But certainly people have veins and tendons showing when they work out as well, and they haven't lost as much subcutaneous fat. But then there's the laxity. I mean, think about it. If you're thin, crawling around the floor, and you're exposed to UV radiation all day long, or if you're driving, or if you're wearing sunblock everywhere else, but you forget about the backs of the hands, eventually they age. And the UV radiation not only breaks down the subcutaneous tissue, but the skin gets thinner. It gets crepey. It gets non-vital. So, do we do a hand in glove? Do we make an incision and pull the skin up? Not a great idea, because skin always stretches. So it might look good, except for the scar, for a little while, but it wouldn't be long lasting. So over the years, we've done a number of things, and they're all integrated together into the recipe to make a better soup. So it depends on what the cause of the hand aging is when somebody comes in. I think one of the first things that people see is they see the red dots and the brown spots and those kinds of things. And as long as they're not a skin cancer, so we look for things, the ABCDEs of melanoma. The A is for asymmetric. If you can't take what looks like a pigmented lesion folded over on itself, it could be worrisome. B is for bleeding. C is for multiple colors. D is for diameter greater than a pencil, greater than about 6 millimeters. E is for elevated. F is an addition of my own, feels funny. And G is for grows really fast. So if you have any of that alphabet soup of worrisome melanoma potential issues, that's a lesion you need to take to your friendly neighborhood dermatologist and get cleared, or we'll ask you to get it cleared before we would treat it in the office. But we certainly have lots of things in the office, depending on the underlying skin type, depending on whether you have had UV radiation exposure and your body's producing pigment, aka tan, that we can do to specifically target the broken red blood vessels, the little ones, or the brown spots or things like that. Now, if the spot is really close to your skin color, it's more difficult to treat, and we may have to use another energy source. But do you want to talk a little bit about intense pulse light and pigmented and vascular lesions?
No, you go ahead.
Well, Staci trains people with this stuff. So, not to go too far down the physics and tissue interactions and things like that, we pick wavelengths whose energy is absorbed by a target, a chromophore. And that particular target, pigmented lesions, it's melanin, and vascular lesions, it's generally hemoglobin. We pick a particular target and we get a wavelength of laser whose energy is absorbed primarily by that target and not by the tissue around it. So the goal is to not cause damage to the tissue around it. So, when you're treating a pigmented lesion, a lentigo, a freckle, or whatever you want to call it, it's flat. It doesn't require to be vaporized with a CO2 laser. We can sometimes use a particular wavelength of laser, and it might be a KTP laser at 532. It might be an ND-YAG laser at 1064. It might be somewhere in between. But usually it's going to be a laser in the visible spectrum or close to it that we can see whose energy is absorbed by that melanin in the pigmented lesion. And we're going to treat it ever so lovingly with just a couple of pulses, and the lesion's going to darken a little bit and shrink up a little bit. Sometimes it'll gray a little bit. We don't want to take it to the point that it totally crinkles up and curdles or gets burnt, because that's more likely to leave us with a hypopigmented scar or a red scar. So we're very careful of how much energy we put into. And then 4 weeks, 6 weeks, 8 weeks later, we can do it again. And eventually we can make that little lesion pretty much go bye-byes. Doesn't mean you won't get them again. If you've made one, you'll make others. We appreciate that. Someone has to put our kids through school. But at least it's something you don't have to worry that it's a skin cancer that needs to be treated alternatively and totally destroyed so that it doesn't spread. Conversely, what if it's a little red dot, a capillary hemangioma, or a vascular ectasia? These are generally on the low pressure vein side versus the arterial side of the circulation. And it's just an oops. There was some trauma. It didn't heal quite right. You got a little capillary hemangioma. Whacked your hand against the door handle or something like that. In people who do repetitive motions with their hands, there can sometimes be injuries from excoriating the tissue, and you can get some little tiny broken blood vessels or UV radiation. Those can all be treated, again, utilizing the proper wavelength, the proper pulse width, the proper spot size. These are all things that we consider in the use of these lasers, or broadband light, whose energy goes from about 600 nanometers up to 11 or 1200 nanometers, so outside of our visible spectrum. But we can use all these little tools, all these little tweaks to create a tool whose energy will be absorbed by the pathology. And we can make it gradually better. The key is gradual. If you're going to someone who says, I'm going to fix that in one visit, be careful. Because then we end up trying to work with the scar tissue. And that's much more challenging. But pigmented lesions and vascular lesions on the back of the hands primarily, occasionally on the palm, are certainly one of the things we deal with. Another thing that early on, before we had the ability to transfer fat from liposuction or just a donor site, or before we had fillers starting back in the early 2000s, we would very carefully sclerose some of the veins on the back of the hand. So we don't want to sclerose all the veins because you need some of them in case you ever need an IV started. And, if you're a little puffy or a little difficult to start an IV on, I'd rather leave those easier to get veins on the back of the hand just for medicinal purposes down the road. But it's not unreasonable in some people who have a lot of duplication of veins to sclerose some of those. So we actually put a compression, not terrible, but a little bit of compression around the lower part of the arm. And we very carefully inject these veins with an FDA-approved sclerosant like polydocanol. Now, whether we're using a direct injection or we're foaming it first or any number of things, you can even, although it's a really, really old, yes, I'm showing my age, you can actually put a stitch at the top of a vein and at the bottom of the vein. And as long as there's no valve in between, you can basically get the body to not use that vein for a while. And after a week or two of not using it, the body collapses the vein, you take the stitches out, but that leaves a little bit of a mark. The sclerosing of the vein generally doesn't, but there may be some trapped blood that has to be removed because the vein cramps down when the sclerosant affects the inside of it. We're actually breaking down the endothelial lining of the vein with the polydocanol. It's like a detergent. And so just like dishwashing soap gets the grease off of your pots and pans, we're getting the adipose endothelial lining of your vein to break down and collapse. And so when the vein's no longer easy to use and the body can't repair it, it either makes a new vein sometimes or it uses the ones that it has. So you have to be careful that you don't just make the vein next to it bigger, but we can do that. So that was sclerotherapy, careful sclerotherapy for the veins on the backs of the hands or the tops of the feet. Of course, we do that from groin to feet after we do the proper ultrasound studies and stuff. That isn't always a cosmetic thing. So sometimes you're going to go to a vascular surgeon who's going to do that with a laser or an RF catheter or something like that, or maybe just tie things off in a little surgery. But back to hands. So we've got some of the veins to go down. We've treated the pigmented lesions, the vascular lesions. What about the volume?
Real quick before you go to volume.
Okay.
The other thing that we see a lot of is the actinic keratoses on the hands. And how do we treat those?
So an actinic keratosis is sort of there's seborrheic keratoses and actinic keratoses. The seborrheic keratoses look like a glued on patch of gum or raisin or something like that. They peel off. They don't generally bleed very much, but then they come back after a while. And actinic keratoses is something that looks a little more flaky. And when you peel it off, it tends to get little punctae, little petechial hemorrhages. and it bleeds, and then it comes back, and then it gets bigger. And you can try all the over-the-counter stuff. It just pisses it off. It doesn't make it go away. So an actinic keratosis versus a seborrheic keratosis. Seborrheic keratosis is really an oil gland-based derivative. And if you vaporize that and take it away, no worries. It goes away. You may have a slightly hypopigmented scar where you took it away, but it's done. An actinic keratosis, you want to make sure that you got all of it, because a certain percentage of actinics gradually, and we're talking over years or decades, go on to become a squamous cell carcinoma. We would much rather treat those when they're benign, not much, than when they need to be tracked down and treated with Mohs or chemotherapy or something like that. So we pay a lot of attention to those. Typically, your dermatologist may treat them early with something as simple as liquid nitrogen spray, or a chemical that, when activated by UV radiation, the sun, a blue laser, whatever, causes the skin cells to break down because of the chemistries that are going on at a cellular level. And, those are, 5-fluorouracil and other things that are used to treat those topically. And they bubble up and get all ticked off, and then eventually peel off and melt away. And when you apply that topical medicine and nothing happens, you've got all your actinics done that day, that place, that time. So once we have all the concerns of cancer out of the way, we still can have deflated hands and deflated fingers. So the gals that come in and they're looking great, they're going to the spa, they're going to the gym, they're working out, we've done their upper neck, lower face lift, we've volumized the face to get them back the Nike swoop on the cheeks and the appropriate jawline, and maybe we've done their upper lids or whatever. We do all those things, and we do our vascular laser, pigmented laser, textural lasers, and energy sources and things like that. And we can do all those things on the back of the hands. We should talk about energy sources for texture and making things thicker. But the volume first is something to consider. And so we used to, back in the 90s and early 2000s, use fat. And fat at that point was a little bit hit or miss because we were using macro fat. Now we use a combination of macro fat, bigger clumps, 1.5 millimeters or so, micro fat, a little bit smaller, nano fat, 400 to 600 nanometers or smaller. So we're getting down to individual fat cells and the rejuvenative milieu that lives amongst those fat cells. There's more stem cells in fat and stromal vascular fraction than there is, for instance, in bone marrow. So if we can get some of those things, then we can slide them through just a small opening, a small needle, into the back of the hand, and we can have those rejuvenative factors and your own platelet-rich plasma working under the skin, then we can help rejuvenate the volume that way, and the skin. We can help make the skin a little thicker, a little more elastic, a little nicer. But back in the old days, all we had was macro fat. We put some macro fat in thinking, well, we're going to keep 40 to 60, 50 to 70%. We're not going to keep all of it. So we always overfilled a little bit. And every once in a while, we'd have somebody who actually had a little extra fat, or they gained some weight after we grafted the fat in the back of their hands and they looked like puffy. So we had to go back and take a little fat out. But the nice thing about fat is generally it goes up when your body weight goes up. It goes down when your body weight goes down. So it tends to look natural. And we can even use it if your rings are hanging loose because you've lost fat around the base of the digits. You can put just a little fat grafted into there. But what if you don't have fat, or you don't want fat, or you don't want to go through a procedure where you have a fat donor area? Now we can use fillers. And there are several FDA fillers that are approved for use on the back of the hands. One of the hyaluronic gels, one of the calcium hydroxyl apatite-based fillers. And so we can use those to make a reasonably lasting volumization, specifically in the back of the hand. So, it takes, in my experience, depending on the filler, the person, everything else, 2 to 4 syringes of these various fillers, whatever you choose. And the problem with using a hyaluronic gel filler is the skin on the back of the hand may be pretty thin. And as light comes in and refracts off the water molecules in the hyaluronic gel, because that's the same gel we use in lips and under the eyes and things like that, it can leave a lovely smooth result. But when the light refracts off of it, it comes back out into what we see as a shade of blue. So if you have someone and you're standing in the grocery store line, you notice that they look like a Smurf, they probably got hyaluronic gel in the backs of their hands, or under their eyes is the other place we see that. So I like to use Radiesse, which is calcium hydroxylapatite. That's the only one that has that. And it's a combination material. It's a microsphere, 30 to 50 nanometer microsphere, about 18 million per syringe, in a carrier gel, methyl cellulose. And you can take that and play with it a little bit, dilute it down a little bit, throw some extra numbing in, and you can use a cannula to very carefully either go from the wrinkles at the wrist or between the web spaces, and you can softly recreate the thenar eminence, the lateral part of the hand, into the individual fingers so your rings fit. I've never taken it onto the palm. Palms don't generally diminish in the same way, but all along the other digits in the backs of the hands blending into here, Radiesse is a great filler. And if you like it, then you can use a long-lasting filler off-label. So Belafil's polymethyl methacrylate, very similar substance, except it doesn't have a calcium moiety in the microsphere, so the body never resorbs it. In the 5-year studies for the face, over 80% of the volume correction was maintained, and in the 10-year numbers, over 70%. So that's a pretty good investment to have that in the back of the hand. Polymethyl methacrylate has been used to make lenses, artificial lenses for eyes, to hold in hip joints and heart valves and things like that. So we've used it in the human body for decades, pretty successfully. Mm-hmm. Certainly, any microsphere filler has to be used artistically so the little microspheres are spread evenly throughout the tissue and don't clump up, because that causes nodules and things that you can feel. So we do a lot of massage afterwards, or the patient does massage to help this while it's setting up in the first 2 weeks afterwards. Mm-hmm. So we've talked about volume. We've talked about brown spots, red spots, benign lesions, warts, and things like that. We just vaporize with a CO2 laser. There's a higher kill rate with CO2 laser, about 85% compared to liquid nitrogen, which is down around 60% or so. And it leaves a nicer healing. It doesn't scar as much, my opinion. So we have lots of alternatives for getting rid of the benign lesions, revolumizing, but we also have to treat the skin and the texture of the skin and the thickness of the skin. So lots of things we do there. We do platelet-rich plasma, and not all PRP is the same. We found out the hard way years and years ago when we were using the little test tubes of platelet-rich plasma with a thixotropic gel in between to separate the red blood cells from the plasma. And we actually measured platelet counts. And we found that some of those tubes reduced the number of platelets in suspension. So when they were supposed to double it or more, they were actually reducing the platelet count. So those PRPs, alleged PRPs that were actually platelet-poor plasma, they worked because of some of the rejuvenative milieu was still there, but not because the platelets were unfolding and releasing all of their factors to grow blood vessels in and to grow nerves in and to repair the tissue and things like that. So we started using a more clinical PRP where we take 60 cc's or more of blood, do a double spin, and we can actually measure the number of platelets that are coming out of you as we draw the blood. So please come in hydrated and eat that day. And then we can measure the number of platelets that we have been able to concentrate. And we're getting 5 to 7 times concentration, which really is what you need to be able to rejuvenate or regenerate. So whether it's into a shoulder, an elbow, a knee, the back of a hand, in a face, anywhere that you want to use regenerative techniques, I like to spray it between the underside of the flap in a facelift and the covering of the SMAS and the platysmal fascia so that things heal and close easier. When we do laser resurfacing, CO2 laser resurfacing, we're putting this high density platelet-rich plasma on the tissue so that the tissue reepithelializes in days instead of weeks, and the redness goes down more quickly. So we can use that tool in the back of the hands, whether we are putting it underneath or whether we're using an energy source like a fractional CO2 or radio frequency microneedling or a fractional non-ablative laser. We have all of those depending on what the patient needs. Obviously, if they have darker skin types or they're going to have pigmentary changes potentially to trauma, then maybe we want to use a fractionated non-ablative laser to cause micro damage to the dermis and cause it to get more lush, or very carefully radiofrequency microneedling or ultrasound. So the new soft wave is a great thing that we're using off-label. So it's not just for the face, not just to lift up the neck, not just to lift up the brows, not just to take the crinkly skin out of the arms and things like that. And we're working on the stomach. We've done part of a study where we've worked on it around the mouth. It got great results. I mean, shockingly great results. And so the backs of the hands are another place. And there's no downtime with that. You put a little topical numbing medicine on, so the treatment becomes pretty inconsequential. And you go about your day after your treatment. Sunblock, of course. But no downtime, no raw spots, no washing, cleaning, balming, any of that stuff that we have with fractional CO2 laser or some of the others. What else do we do? What are we leaving out to throw down the gauntlet about hand rejuvenation?
I think you've pretty much covered it, but I think this is one of those things where so many women just aren't aware that there is something that we can do, or many things that we can do to rejuvenate their hands, because they work on their face and their body, but it's the hands and neck we usually see can tell the age. And if they haven't had any work done to or if they've had work done to their neck, it's their hands that'll always give it away. And so it's important for women to know, and men, that there's a lot we can do.
Yeah, because we can cover up some of the arthritic changes, osteoarthritis, where the knuckles get bigger sometimes. We can blend that tissue in and give them volume along the digits, particularly the ones, close into the body of the hand. And, if someone has extra sweating, hyperhidrosis, you go out to shake their hand, we can even use neuromodulators to inject into the palm of the hand. Again, tiny needles after a topical anesthetic. It's not as bad as you think. And they can be warm and sweat-free for months and months at a time. That really changes people's lives in a very positive fashion.
Yeah, it does.
So, okay. Well, anyway, so that's a little bit about hand rejuvenation. You may not be a hand model, but chances are you have hands, or at least one hand, that may require a little bit of rejuvenation, particularly in comparison to the rest of your body. So think about fat, fillers, toxins, energies, sclerotherapies, appropriate pigment and vascular lasers, all those kinds of things that we have in our armamentarium to rejuvenate hands. So thanks for listening. Look, listen, share, send us questions on your favorite podcast channels and media. If you're looking at us on YouTube or want to, that's at the Dick Doc, DICKDOC. And you can see us in person and tune in for another segment of Aesthetic Revolution, the podcast, coming to you in the near future. Thanks.